Jagnany sir for giving me this opportunity to share my experience and my knowledge about diabetic retinopathy. We all, ophthalmologists, physicians, clinical cardiologists, or endocrinologists or diabetologists, we often see the same patients, same diabetic patients. And diabetic retinopathy is most common microvascular complication of diabetes. And it is one of the leading causes of irreversible blindness and visual impairment in our patients. And many a times patients don't have that insight that yes, the diabetes can affect their eyesight. And diabetes can affect the eyesight in many ways. And it has been related as a possible risk factor with many eye conditions like retinal venous occlusions, arteriolar emboli, retinal arteriolar occlusions, and some corneal diseases, especially related to erosion of the corneal epithelium or causing persistent epithelial defects. And there are some diseases like glaucoma, maybe primary open angle glaucoma or neovascular glaucoma, even ocular ischemic syndrome, which are for which diabetes has been known as a risk factor. But there are few conditions where definitely diabetes is associated as a risk factor, which are cataract, anterior ischemic optic neuropathy, diabetic papillopathy, ocular movement disorders, and diabetic retinopathy. So we see there are a lot of conditions, a lot of ways in which that a diabetic patient can be affected and his vision can be affected due to uncontrolled diabetes. But diabetic retinopathy definitely is the foremost among all of them. So we all know what is retina. Retina is the neurosensory layer of the eye, and it has got 10 layers. And starting from internal limiting membrane to pigment epithelium, retinal pigment epithelium. And this is how a healthy retina looks. The picture on your right side is a fundus photograph of a healthy retina, which shows the normal arteries and veins. This circular thing in the center is the retina, is the optic nerve head. And this area, the central area of the retina, which is between the superior and the inferior temporal vascular arcades, is the macula, which is the center for the vision, main primary center of the retina, which is responsible for the vision. And this is how a diabetic fundus or a retina affected with diabetic retinopathy will look like, showing a lot of dot and blot hemorrhages, few hard exudates. These white spots are few hard exudates, which are nothing but lipids which have leaked out of the vasculature. And these are hemorrhages, blot hemorrhages, flame-shaped hemorrhage, and some few microaneurysms are also seen. So what is the burden of the disease? See, currently it is estimated that our country is having almost 30 million 30 million patients of diabetes were there in the year 2000, and it has been estimated that we'll be having almost 80 million patients of diabetes by the year 2030. That is just 7 years from now. And almost two-thirds of all the type 2 and almost all of the type 1 patients of diabetes will have diabetic retinopathy over a period of time. And in general, the prevalence of diabetic retinopathy in diabetics in our country is from 18 to 22%. And this translates into a huge number of patients of diabetes, of diabetic retinopathy, and which has been estimated to be around 15 to 16 million by the year 2030. So that we are sitting on a time bomb, literally sitting on a ticking time bomb, or we can say that we are waiting for a tsunami of patients having diabetic retinopathy. Somebody. Okay. Now, as a cause of visual impairment, almost 1% of the patients of diabetic retinopathy, is responsible for visual impairment of almost 1% of the patients, and same 1% is the ratio for patients who are having blindness. The best predictor of diabetic retinopathy is the duration of diabetes. After 20 years, almost 99% of the patients with type 1 diabetes and almost 60% of patients with type 2 diabetes will have some degree of diabetic retinopathy. And overall, if you see, almost 33% of patients with diabetes have signs of diabetic retinopathy. And people with diabetes are almost 25 times more likely to become blind as compared to the general population. Now, how does diabetic retinopathy happens and what is the pathological process? Basically, hyperglycemia causes regulation of few metabolic pathways, which leads to oxidative stress, inflammation, and vascular abnormalities, and angiogenesis and retinal neurodegeneration. The main metabolic pathways which get affected are the polyol pathways, the formation of advanced glycemic end products, PKC activation, and I will not go into the details of these pathways, but normally this alteration of these metabolic pathways, they cause osmotic stress on the cells, and the deposition of advanced glycemic end products causes glycemic damage, hyperglycemic damage to the cells and tissue proteins of the cells. And this leads to inflammation, and which is the key driver of capillary occlusion and hypoxia, that drives expression of the vascular endothelial growth factors, which leads to angiogenesis, which leads to proliferative type of diabetic retinopathy. This flowchart, in a simplified manner, it depicts how hyperglycemia or uncontrolled diabetes is related to vision loss. Basically, there are three reasons for vision loss in a patient with diabetic retinopathy. One is macular edema, one is the neural dysfunction due to hyperglycemia, and another is the vitreous hemorrhage. These three are the main reasons why patients get vision loss in diabetic retinopathy. The whole pathophysiology is because of microvasculopathy, and which causes retinal capillary occlusion and retinal capillary leakage. Now, microvascular occlusion due to the inflammatory process, this causes thickening of capillary basement membranes and abnormal proliferation of capillary endothelium, which leads to increased platelet adhesion. Once platelet adhesion is increased, that causes the microvascular occlusion. And this microvascular occlusion causes ischemia of the retinal nerve layer fiber and infarction, infarction of the retinal nerve fiber layer, causing cotton wool spots, which are known as soft exudates. And this ischemia also causes increased expression of the vascular endothelial growth factor. Now, this vascular endothelial growth factor is, as I had told previously, is responsible for neovascularization or angiogenesis. These new blood vessels, which are formed on the surface of the retina, they are quite fragile, and they can sometimes lead to spontaneous hemorrhage, leading to vitreous hemorrhage, which again will cause decreased vision. And this, if they get organized, this neovascularization stands for long, they can get organized into fibrovascular bands, leading to tractional retinal detachment and neovascular glaucoma. All these three can, that is vitreous hemorrhage, neovascular glaucoma, and tractional retinal detachment in proliferative diabetic retinopathy, they can lead to visual loss. The other method of visual loss is because of microvascular leakage. The impairment of because of deposition of advanced glycemic end products, the endothelial tight junctions, they got impaired, and there is loss of pericytes in the loss of pericytes in the capillaries. This leads to weakening of the capillary walls and can lead to leakage from the capillary walls, leading to macular edema. The leakage of lipids can lead to deposition of hard exudates and again retinal hemorrhage. Now, what are the risk factors of diabetes? We all know that of diabetic retinopathy, that the duration of diabetes is the most important risk factor. And the control of, definitely, if the diabetes is not under control, the patient is again at a higher risk of getting diabetic retinopathy. Apart from that, hypertension, dyslipidemia, they can also contribute to increased chances of getting diabetic retinopathy. Then patients with gestational diabetes are again at higher risk of getting diabetic retinopathy. And most of the times, now coming to the symptoms. Now, how do we know? How do a general physician or a patient or a doctor who is not used to seeing the fundus will know that a patient is getting diabetic retinopathy or not? So most of the times, diabetic retinopathy is asymptomatic. And even in early stages, like in stages of mild diabetic retinopathy or moderate retinopathy, patient will not complain directly about the eyes unless and until the patient starts getting macular edema or proliferative changes leading to vitreous hemorrhage and all. The patient doesn't complain. The complaints which they may get after they're getting a complication of macular edema or vitreous hemorrhage are related to blurring of vision, fluctuation of vision, floaters, distorted vision. Sometimes macular edema can cause elevation of the fovea, which makes the vision distorted. That means if you try to read, you may find that the letters become uneven. The letters or the image which is being formed at the retina, it becomes uneven. You can get scotomas and poor night visions, and there can be partial or total loss of vision. But all these symptoms you will get only in advanced stages of diabetic retinopathy. Diabetic retinopathy is classified in the form of non-diabetic retinopathy and proliferative diabetic retinopathy. A non-proliferative diabetic retinopathy, that is NPDR, we normally would see prescriptions from ophthalmologists mentioning NPDR and PDR. So NPDR is the non-proliferative form, which is again classified in mild, moderate, and severe forms. And proliferative diabetic retinopathy is the one where we get new retinal vascular vessels. There is a international clinical diabetic retinopathy disease severity scale, which classifies this diabetic retinopathy. And the first stage is where there's no apparent retinopathy. Then there's mild non-proliferative diabetic retinopathy, where you see only a few microaneurysms in the retina. And then moderate non-proliferative, moderate NPDR, which is something which is between the mild and the severe form. And the severe form is being defined as having any one of the following, that is more than 20 intraretinal hemorrhages in each of the 4 quadrants of the retina, or a definitive venous bleeding in 2 or more quadrants, or a prominent edema in 1 or more quadrants, and there are no other signs which are related to proliferative retinopathy. So, and PDR is defined as any one or both of the following, that is either neovascularization or vitreous or pre-retinal hemorrhage. If there is a vitreous hemorrhage or a pre-retinal hemorrhage, you straight away classify it as a proliferative diabetic retinopathy, even though you may not be able to see any frank neovascularization on the fundus. This is how a mild NPDR looks. The first photograph on the right top corner, if you can see this small dot hemorrhage, which is actually not a hemorrhage, a microaneurysm in the superinasal quadrant of the retina. And this second picture on the top left corner is of a moderate retinopathy, and the third one is of a severe non-proliferative diabetic retinopathy. This is how a neovascularization looks. If you can see, these are the normal vasculatures, the prominent vessels which you are seeing, and these fan-like structures which are seen are of the new vessels or neovascularization elsewhere. Now, neovascularization is classified as either NVE or NVD. If the neovascularization is on the optic disc, it is known as NVD. Otherwise, it is known as a NVE. So, and if you do a fluorescein angiogram to detect whether it is actually a neovascularization or not, you will have this kind of picture where you can see a lot of early leakage of dye around the disc and in the retina. So this patient has both NVD and NVE. Now, what is the high risk? There are few high risk characteristics of PDR where the patient is at the risk of serious vision loss. These are presence of vitreous or pre-retinal hemorrhages, presence of neovascularization, of course, and location of neovascularization or near the optic disc. So if the patient is having NVD, then it falls into the high risk category of PDR, where the patient is at a serious risk of loss of vision. Now, this is how a vitreous hemorrhage will look on fundus, on examination of the fundus. Most of the times when the vitreous hemorrhage is severe, we are not able to see anything. There's no details of retina or the vasculature or vessels of the retina or optic disc are seen. This photograph shows a picture of pre-retinal hemorrhage, large pre-retinal hemorrhage. And this one is an advanced stage of proliferative retinopathy, where there is a large proliferative band, where fibrovascular band is seen attached to the disc and causing tractional retinal detachment. And the other mode of visual loss, apart from PDR, vitreous hemorrhage and proliferative diabetic retinopathy, that is as discussed earlier, is macular edema. The easiest way to diagnose macular edema is on the fundus examination. And with the help of an OCT or optical coherence tomography, we can see with the help of an infrared laser, we can see a cross section of the retina, which shows the cystic spaces inside the retinal nerve fiber inside the retinal layers, and which is significantly pathognomic for macular edema. So diabetic macular edema is prevalent most as the stages or severity of diabetic retinopathy increases. The chances of a patient getting diabetic macular edema increases. The prevalence is highest in proliferative diabetic retinopathy and least in mild NPDR. It's not that mild patients with mild NPDR will not get macular edema, but yes, the chances of getting macular edema in mild NPDR is very less. Hardly 3% of patients with mild NPDR show up with macular edema. How is how can we prevent getting diabetic retinopathy? Now, 90% of diabetic eye disease can be prevented simply by proper regular examinations of the eye and treatment, and by controlling blood sugar. And the best measure for prevention of loss of vision from diabetic retinopathy is strict glycemic control. See, the most important predictor is the duration of diabetes, but we cannot control that. A patient who gets diabetes at a younger age, or patients with type 1 diabetes, they have a whole lot of life remaining ahead. So the chances of them getting diabetic retinopathy is very high. But we can still prevent, or we can delay the onset of diabetic retinopathy if we can get a very good and strict glycemic control. And the primary prevention is definitely what I discussed earlier, like strict glycemic control and blood pressure control. Secondary prevention can be done by annual eye exams, the schedule for which I'll be discussing later in my next upcoming slides. And definitely the tertiary prevention of loss of vision due to diabetic retinopathy is with the help of the surgical treatments or laser treatments which we do for these patients. The management of diabetic retinopathy depends upon maintenance of HbA1c between 6 to 7% and control of associated conditions like hypertension, hyperlipidemia, anemia. All these three conditions, or renal disease also, all these conditions, they enhance, or they speed up the process of getting diabetic retinopathy. Or patients who already have, say, mild or moderate diabetic retinopathy, if the patient has got uncontrolled hypertension or hyperlipidemia or anemic patients, the diabetic retinopathy can easily get into advanced stages, and you can get complications very early in patients who have the uncontrolled systemic conditions. And the treatment of diabetic macular edema is dependent. We don't normally treat mild to moderate diabetic retinopathy, or for that matter, severe diabetic non-proliferative diabetic retinopathy, unless and until the patient has diabetic macular edema, or patient has macular edema which is threatening to cause visual loss. The mainstay of treatment of diabetic macular edema nowadays is anti-VEGF therapy, which, as I discussed earlier, that vascular endothelial growth factors are responsible for neovascularization and capillary leakage also. And these anti-VEGFs, namely drugs like ranibizumab or bevacizumab, they are antibodies against these vascular endothelial growth factors. And intravitreal injections of these anti-VEGF agents can help in reducing diabetic macular edema. Other agents, other intravitreal agent is steroid triamcinolone acetate, which when given in intravitreally can also help in decreasing diabetic macular edema, but it is not nowadays not the first choice drug. Before the advent of anti-VEGF, triamcinolone was the first choice drug, but it has got some inherent complications or chances of side effects like getting cataract because of the steroid, or glaucoma because of steroid. So it has now, in the pecking order, it has become the second drug of choice for intravitreal injections. Other things, which other modality, which is a laser photocoagulation, a grid laser of the macula, it was used before the advent of anti-VEGFs. Now again, it has gone down in the pecking order for treatment of macular edema. These anti-VEGF agents I have already discussed. And treatment of PDR is dependent on pan-retinal photocoagulation. where if the patient does not have vitreous hemorrhage and we detect that, yes, the patient is getting neovascularization of the disc or the neovascularization of retina elsewhere, a pan-retinal photocoagulation is done where we do laser photocoagulation of the whole retina, sparing the macula. By doing retinal photocoagulation, we decrease the oxygen demand of the retina. As I initially discussed during the pathophysiology section of diabetic retinopathy, the main cause of PDR or main reason of getting complications of diabetic retinopathy is ischemia. So once we decrease that oxygen demand of retina by doing, basically we burn out the peripheral retina, since the central part or the macula of the retina is more important for vision, and we burn the retina with the help of lasers, the peripheral retina, so that the central vision is maintained, and the whatever oxygen supply to the retina is there, that can be directed towards the macula. And once you start getting complications like vitreous hemorrhage and proliferative vitreoretinopathy, tractional retinal detachment, then vitrectomy is the only treatment which will help in restoring some vision of the patient. Now, the recommended schedule for eye examination for patients with diabetes is, for type 1 diabetes, is that it should be the first examination should be done at least within 3 to 5 years after diagnosis. And after that, an yearly follow-up should be done. And for type 2 patients, since we all know that we don't know many a times that since how many years the patient might be having type 2 diabetes before getting diagnosed, the first examination, eye examination, should be done immediately at the time of diagnosis. And then again, the recommended follow-up period is an yearly eye checkup. And if a patient of type 1 or type 2 diabetes gets pregnant, ideally an examination, or is in the, say, just age group where the patient is likely to get pregnant, an eye exam should be done prior to conception and then early in the first trimester. If there's no retinopathy in these patients or moderate NPDR is there, then an eye examination is recommended every 3 to 12 months. If it is either severe NPDR or worse, then it should be done once every 3 to months, once every 1 to 3 months. Now, once you send the patient to an ophthalmologist, say immediately for the first examination, after that, the ophthalmologist will decide the further follow-up examinations. If the patient is not having any diabetic retinopathy, then or maybe even up to mild diabetic retinopathy, then the follow-up period is once every year. If the patient is having anything like mild diabetic, moderate diabetic retinopathy, non-NPDR or severe NPDR, then the follow-up period will decrease, say, to around 6 months to 3 months. And in cases of high-risk patients, with high-risk characteristics of PDR, we may call patients for monthly follow-ups. Screening of, as I discussed, the screening of eye examination of all patients of type 2 diabetes is to be done at the time of diagnosis and all. And the patient should be advised to stop smoking and exercise regularly. And we all know that the eyes are windows to the soul and body, and all the patients with cardiovascular diseases and diabetes should undergo regular ophthalmic exams. And the teamwork and coordination between the cardiologist, diabetologist, ophthalmologist can help in preservation of the eyesight and management of the systemic disease as well. Many a times we'll have patients who will be very rigid, very reluctant to get their eyes examined, and they will not listen to us. But yes, as Helen Keller has said previously, that alone we can do so little, but together we can do so much for our patients. And thank you. That's